Dear Chairman, dear colleagues, firstly, I would like to thank the organizing committee, Professor Mike Chen and his team, for the opportunity to participate in this exciting conference. It's a great pleasure that our cooperation, which began recently and is confirmed by a signed memorandum, includes not only scientific research and new publication, but also conference, which I hope will be valuable for medical community. It's my disclosure. I am co-researcher who developed the Ukrainian version of FRAX and its cutoff value. Also with my team, I am responsible for Ukrainian translation of FRAX and FRAX Plus on their native websites. As previous speaker discussed, osteoporosis is the most common metabolic bone disease which increases rapidly with age and has a critical medical and social burden. Osteoporosis was firstly defined by the consensus group in 1994 as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration with a consequent increase of bone fragility and risk of fractures. This disease is a silent epidemic with no or minimal initial symptom, like other latent diseases as anemia, hypertension, or end-stage renal disease. These conditions are difficult to distinguish from the norm until they advance enough to create measurable symptoms, by which point this disease may be irreversible. The low-energy fractures are crucial osteoporosis consequences with a substantial social and medical impact. Worldwide, up to 37 million fragility fractures occur annually in subjects over 55 years old, the equivalent of 70 fractures per minute. Worldwide, in 3 women over age 50 will experience osteoporotic fractures, as will 1 in 5 men. Low-energy fractures of the hip, spine, forearm, and proximal humerus are defined as major osteoporotic fractures. They account for approximately 80% of fractures and majority of the economic burden. These fractures are strongly associated with low bone mineral density, are predictive of future fractures, and display an age-dependent patterns. The primary goals of osteoporosis treatment is to reduce the risk of fragility fractures. Thus, the ability to assess fracture risk is critical in identifying patients who are eligible for intervention. Therefore, early diagnosis of osteoporosis is crucial. Dual energy X-ray densitometry DEXA was approved by FDA for measuring bone mineral density in 1988. Since this day, it has remained the gold standard for diagnosing osteoporosis. A few years later, after FDA approval, osteoporosis was defined by WHO working group in densitometric terms as a BMD that was 2.5 standard deviation or more below the mean value in young, healthy women's scores. And since then, the global medical community, represented by the International Society of Clinical Densitometry, has continually updated the recommendation for the use of bone densitometry. Despite the crucial role of BMD in fracture prediction, it has several critical limitations that compromise its utility in identifying patients with high risk of fractures. The most important one is high BMD specificity and low sensitivity, and the fact that the majority of fracture, approximately from 60 to 70%, happened in subjects without osteoporosis. Sometimes bone mineral density may not be available or reliable, either due to limited access to facility or individual patient issue, such as degenerative changes in the spine or hip replacement. Moreover, the significance of any given T-score threshold differ by age. For example, T-score of -2.5 in a woman age 65 years old demonstrates the modest increase in the fracture risk compared to the females with no clinical risk factors. With increasing age, the differences in the probability between subjects with T-score of -2.5 and the general population decreases, and in the older ages, the fracture probability progressively decreases compared to age and sex-matched general population. Furthermore, many clinical factors don't act solely through BMD and thus maybe provide an additional independent contribution to risk stratification. Finally, fracture rate differ between countries, and this variation cannot be explained solely by bone mineral density. For example, T-score corresponding to the 10-year probability of major osteoporotic fracture of 20% varies from -4.6 in Venezuela to -2.0 in Iceland. In summary, BMD does not fully capture the likelihood of fractures. This leads to the adverse consequences that patients with high risk for non-BMD reasons have been denied appropriate treatment because the threshold for densitometric osteoporosis cannot be reached. On the other hand, we know well that numerous clinical factors increase the risk of osteoporosis and its complication. Some of them are modifiable, others are not. Many studies confirm that an increase in the number of clinical risk factors of osteoporosis leads to a greater risk of the fractures, and their combination with low bone mineral density leads to an even more pronounced increase in the fracture risk. Women with multiple risk factors for osteoporotic fractures and low BMD have especially high risk of hip and vertebral fractures. Previous studies have demonstrated risk gradients for fracture prediction using clinical risk factors alone, femoral neck BMD alone, and their combination, confirming that combination is the most effective approach for this purpose. Several well-validated assessment tools for fracture risk assessment are now available, including 1-minute IOF test, the GAD1 fracture and Q fracture calculator, as well as others. They take into account the age, sex, history of smoking, alcohol intake, previous fractures, parenteral history and glucocorticoid use, some causes of secondary osteoporosis, history of falls, and other factors. Some of them include BMD, others don't. However, the most widely used and adopted calculator for fracture risk assessment is FRAX. It is a computer-based algorithm that calculates 10-year probability of the major osteoporotic fractures and hip fractures. It was developed in 2008 by the WHO Collaborating Center in the University of Sheffield in the UK. Through a series extensive meta-analysis from 12 prospective population-based study from North America, Europe, Asia, and Australia, with a total more than 60,000 men and women, several risk factors were identified and incorporated into the tool. FRAX has been validated using 11 independent cohorts that didn't participate in the model synthesis. One of the main aims of the tool was to make it easily accessible and simple to use in primary care. Thus, FRAX used 7 simple and widely available clinical risk factors, inserted as yes or no in the calculator: prior fragility fracture, parenteral hip fractures, smoking, systemic glucocorticoid use, excess alcohol intake, rheumatoid arthritis, and other causes of osteoporosis. The other factors included in FRAX are age, sex, and body mass index. FRAX can calculate the fracture probability with or without femoral neck BMD, so accommodating situation where densitometric assessment is not available. The development of country-specific FRAX model is significant because age-specific rates of fracture and death vary across different populations. In Ukraine, we have our own version of FRAX created as a result of our epidemiological study. Malaysians can also use their own version of FRAX by selecting a continent, Asia, a country, Malaysia, and one of the 3 population groups in the calculators. Another available Malaysian fracture risk calculator is Osteoporosis Self-Assessment Tool for Asian, OSTA, which has been studied and validated for the local population. However, its use is more limited than FRAX. Return to FRAX. The calculation led us to determine the 10-year probability of major osteoporotic fractures and separately hip fractures. These parameters can be used for further management of osteoporosis even without BMD assessment. Today, 3 approaches are used for the management of osteoporotic fractures. The first used fixed value, the second employed an age-dependent approach, and the third is the hybrid approach, which combines the first and second models in different sequences. This depends on the country and their recommendation. Where assessment is made without BMD, the FRAX calculation allows us to categorize the patient into one of the 3 groups. The red zone includes the subject with high risk of osteoporotic fracture requiring anti-osteoporotic treatment even without DEXA. The green zone is for low-risk patients who require neither osteoporotic treatment nor bone density examination. And orange zone includes subjects who require additional examination. When the patient results fall into the orange zone, we use the interventional threshold parameters, which divide the examined subject into 2 groups: those with a high risk of fractures and those with a low risk. The first group requires anti-osteoporotic treatment and the second one doesn't. In Ukraine, we have our national threshold parameters developed based on our own Ukrainian studies, and we employ an age-dependent approach for FRAX use. The current Malaysian clinical practice guideline for the management of postmenopausal osteoporosis, published in 2022, also suggest a choice of treatment tactic for postmenopausal osteoporosis based on the risk of osteoporotic fracture, but propose the treatment initiation for patients with osteopenia and FRAX score more than 3% for 10-year probability of hip fractures and more than 20% probability for major osteoporotic fractures. However, the recently published study from Malaysian authors has confirmed the possibility of using an age-dependent approach in fracture risk assessment. This study demonstrates that less than half of the study population require BMD for osteoporosis treatment when age-specific assessment thresholds were applied. Therefore, in more than half of cases, therapeutic decision can be made without BMD based on this assessment threshold. As I have already mentioned, FRAX was developed in 2008, and since its release, it has been used to assess fracture risk for more than 80% of world population. It has highlighted the differences in fracture risk worldwide among women and men. FRAX was developed as a living tool and it changed over time. At the slide, you can see two FRAX algorithms proposed in 2011 and 2021. New study enable the collection of new data on the capability of FRAX. Also, approaches to use and interventional threshold as defined by FRAX differ across countries. As I have already mentioned, FRAX is a crucial tool for selecting the optimal strategy for managing osteoporotic fractures. In subjects with low risk of fractures, optimization of calcium and vitamin D intake, physical exercise, and advice concerning lifestyle, smoking, and alcohol cessation are recommended. In subjects with high risk of osteoporotic fractures, along with optimization of calcium and vitamin D supplementation and physical exercise, the prescription of oral bisphosphonate or other anti-resorptive drugs should be considered. In patients with very high risk of osteoporotic fractures, along with supplementation of calcium and vitamin D and physical exercise, the possibility of osteoanabolic anti-osteoporotic drug use with subsequent appointment of anti-resorptive medication should be chosen. Over the year, FRAX can be criticized for several issues, particularly for its limited in the number of risk factors. However, FRAX was designed to be a simple, accessible, and easy-to-use tool for primary care. Therefore, most questions in the tool only accommodate a yes or no answer. This means that risk factors, which are number or dose dependent, are not fully captured. Examples include number of prior fractures, the consumption of alcohol, and the dose of glucocorticoid. Other concerns include the lack of provision for lumbar spine BMD and the absence of measurement of the material or structural property of bone. Finally, the bone of parenteral fracture might be of interest. Recently, the new version of FRAX has appeared and is being actively studied, FRAX Plus. We have already translated FRAX Plus into Ukrainian for our medical community and are adapting it to the Ukrainian population. This tool has additional questions on the risk of osteoporosis that are important for osteoporotic fractures, presence of diabetes mellitus, falls, type of fractures, etc. And we hope that this tool will be even more helpful for the widely assessment of fracture risk in target population. In conclusion, I would like to repeat that FRAX is a globally leading tool for fracture risk assessment, incorporated in more than 100 national and international guidelines. FRAX has been designed as a living tool and it adapts constantly for more country and territory, for more languages. And in addition to the information about treatment decision, it can also be used to guide assessment with BMD more efficiently. The cost effectiveness of such approaches has been demonstrated as the potential utility of FRAX as core of approaches to population screening for higher risk of fractures. And the new FRAX Plus website will permit modification of FRAX probability to account for a range of additional clinical consideration, and the second version of FRAX is under development. I would like to thank you for your attention, and also I would like to thank to my collaborator who help us to develop the Ukrainian version of FRAX, who help us to translate it for our medical community. I would like to thank to my team who stay in Ukraine and continue our fight. I will be very pleased to answer your question. Thank you for your attention.